Thank you. Thank you so much. It's a pleasure to be here. I actually got interested in childhood obesity initially because of my work in the eating disorder area. We were looking at what sets people up for the development of eating disorders, and we found that children with obesity were at a lot higher risk for eating disorders. And also when we looked back at the onset factors among people with bulimia nervosa and binge eating disorder, childhood obesity was a risk factor. And you can imagine the bullying, the stigma, the body image concerns, it all begins to set these kids up for vulnerability. So coming from this mental health background, my heart just went out to these kids. And so this was really a long time ago in the mid-90s when we found out this information. So I'd like to just talk with you a little bit about our work at the state. I actually grew up in Missouri, so it was really thrilling for me to be able to work on this committee and look at both prevention and treatment. And what we were excited about is that we had a work group from across the state and also the key stakeholders in Missouri in terms of from the Department of Education, the Department of Health. We have MOCAN, so we had a lot of opportunities to really interact around what were key issues, and we decided to try to really be focal, knowing that it's better to have these actionable items. And so one issue that the group really felt was important were the child care guidelines, because those actually have not been updated in about 20 years. And obviously we have a lot of science now on eating and activity behaviors. And so that work is now underway. And then also at the school level, unfortunately, rates of physical activity classes have really dropped off. My children lucked out, and they've been in a school that has had physical activity every day. And when I talk with people around the state, that is a rarity that kids have that luxury. And so that's another thing that's being put in place at DESE is that there is now a school wellness coordinator to look at guidelines across all the schools in the state of Missouri. So that's underway, so we're very excited about that. And then the Child Health and Wellness Commission, there are beginning seeds of having that all put together as well. But again, each of these things are a work in progress. And then the community, we're really thought that also having centers of excellence within the communities could be very helpful, because it's worked really well in our state for the treatment of autism. So that's another issue that we've it's been a little bit more on the back burner. But one thing that we're really excited that we've been able to move forward with has been the treatment recommendations based on the receptivity of Mo HealthNet. And so I'm really delighted that Summer's here today to talk with you about the work that's underway. And I want to just give you a sense about sort of what the committee recommended. So what we really wanted to do was to try to get health care coverage. And for me, it was a real eye-opener, because I'd done all this work in there of eating disorders, what's the best treatment, how do we best treat them. I personally didn't have to fight to get health care coverage for individuals with eating disorders. Now, I know somebody fought that battle, and it's a very noteworthy and important battle, but the problem has been, and most people are surprised, kids with obesity, they do not get health care coverage at all. So it's very important that they get this health care coverage, because what we know is that with obesity, with children it tracks and kids get worse. And if you want to know who's going to develop severe obesity, tune into what a 5-year-old's weight is. Out of San Diego, Phil Nader has done really super work to show that the overweight actually tracks and leads into obesity, and that's been replicated numerous times. So if you think about from a prevention model, we've done a lot in the eating disorder world, that if you think about every woman being at risk for an eating disorder, but in reality, most women don't develop eating disorders. But if we go after the women who have high body image concerns, we follow them. They convert and cross over much more frequently. So if you're going to have a targeted intervention, you go after this targeted group. So we've been very successful with that with eating disorders, so it made sense to me that we could do that with childhood obesity. And I want to give you a bit of an example. If you have a child who's at the 97th percentile and they're 8 years old, over the year, they only need to lose 4 pounds to drop into the normalized weight range. And we have several kids right now that we're treating that are just like that, that they came in, they met standards for obesity, but now they're have what we call a normalized weight. Now, fast forward that child, now they're still at the 97th percentile. We don't see that many kids at the 97th percentile. Children who have obesity, they have much more severe obesity because obviously severe obesity, people know it's the highest rising thing in kids. So the 97th, what we find is by 12 years old, they need to lose 16 pounds, a girl, if she's at the 97th percentile. Now, fast forward even more, we don't catch her, we ignore it. Some healthcare providers unknowingly would say the child would grow out of it. Well, we find they don't, and now you fast forward, and by age 18, you want to know how much that 97th percentile child would have to lose? They'd have to lose 65 pounds. And how many of you have lost 4 pounds? How about 16 pounds? Okay, how many have lost 65 pounds? Yeah, it's not very common. So I think those are the things, just getting you thinking about what would be the advantage of early intervention with these children. And the problem is, even if you intervene with that 18-year-old, it gets worse. The severity of obesity gets worse. I was asked to speak last year to the National Academy of Sciences because of their concerns about disability and obesity. And what they're seeing is individuals who have mental health disorders and obesity. There's so many people who are above the BMI of 60 who have disabilities. So you can imagine if we can even catch that kid at 18, and even in the worst case scenario, we just prevent further weight gain, that's a success. So those are the things that as a committee we really wanted to bring to the forefront, because most people do not realize these kids don't get treatment, and most individuals who have obesity don't get any care. The only thing now that has started to be reimbursed in any kind of systematic way is bariatric surgery. Well, I think it's a shame to wait till a kid has to have bariatric surgery. So this was really the issue that we wanted to bring to the legislators in the state of Missouri, and Dr. Hampel's a pediatrician. She did an amazing job really articulating the health consequences for these kids. So many of these kids are already by adolescence. They have orthopedic problems. Can you imagine being 16 years old and having back pain? That's a big problem, and that's just, if a child is already having those orthopedic problems, you can better believe that they have the high blood glucose or at elevated risk for type 2, or they have type 2, they have fatty liver disease. There's over 30 diseases these kids can develop now. And I've treated now, through the Today's study, we treated over 700 kids with type 2 diabetes, and in a 10-year period, the advancement to other comorbidities was so much faster among kids than what we see with adults. So that's kind of the background. I'm very passionate about this topic. We had a very passionate group of individuals. What we wanted to do is to see whether or not we could get the recommendations to reimburse the licensed professionals, and we decided to recommend multi-component family-based treatment. So I wanted to walk you through why did we do that, what's the literature to support that. So the U.S. Preventive Service Task Force recommendations, they first came out in 2010, highly recommending that kids get this care, that pediatricians should identify children who have obesity, and they should be recommended for multi-component treatment because the evidence was already that strong, and they have very specific evidence-based review guidelines. They updated it in 2017, and what they recommend is that the children or adolescent who has obesity, that they get greater than 26 contact hours over a period of up to 12 months to improve their weight status. And actually the data are pretty good for 2 to 5-year-olds as well. And I was just on the American Psychological Association guideline panel because they had funding to do even more extensive reviews, and those recommendations came out for the 2 to 5. Now in the state of Missouri, we're focusing more on the group that is it Summer, is it 5 years old that we're recommending, or is it 6? 5. So that's good. So we did get the 5 because this is 6. So we were pleased with that. And I think it's kind of a great opportunity to get these kids. So this is just kind of the meta-analyses. And all I really want you to pay attention to is in the red. This is really low-dose treatment, low-dose intervention, maybe 5 sessions with a provider, a pediatrician, some counseling, no impact of the intervention. You can see the higher dose interventions getting above the 26, and the higher the dose, the better the intervention. And I like to liken it to something like playing tennis or soccer or any sort of sport where you're developing a skill. You can imagine that if you go out one time and someone, I mean, my daughter, she's really cute. She thinks I put her to tennis camp and told the instructor she was a beginner, and she was so offended because she played just a couple times. But then by the end of the week, she realized that actually she is a beginner. But the thing is, it does take a lot of skill to develop these eating and activity habits and really to ingrain them over time. And I think you can see that with the higher dose treatments, so that there's been mounting evidence for treatments. I'm just going to show you some of the meta-analyses and systematic reviews that show that there are positive effects of these family-based treatments on child weight and cardiometabolic outcomes. And the data show that the diet and activity behaviors are changing as well. Obviously, those are harder to measure, so we focus on the weight as a proxy for the diet and activity, but we get those as well. And also that the dose is related to outcome. This is just a data slide to show you, well, not a data slide, but a graphical representation of the work that's gone on since 1980 to validate family-based treatment for the treatment of pediatric obesity. And I thought it'd be kind of nice to show you the progression. So the original study that was done by my colleague Len Epstein showed that it isn't sufficient for kids to just get education alone. They really need to have a focus on the behavior change to get the better weight outcome. The next study he did was really looking at active parent involvement, that the more the parent is involved, the better the child does. If you target the child alone or you target the parent alone, they do less well than when you target the two together or you have a non-specific target. So that started becoming the gold standard for treatment of childhood obesity, and there are still mental health disorders where you just target the child, but for childhood obesity, the gold standard would be to target the parent and target the home, and it makes a lot of sense because up to 70% of calories are consumed at home. The next study that he did, which was interesting, he looked at lifestyle or aerobic activity versus calisthenics and found a superior effect of lifestyle activity over structured exercise classes that had more calisthenics. So it was really a nice demonstration to show that the bouts of activity you can get, that it doesn't have to be this vigorous activity, that it can be lifestyle activity that you work in. And then so I thought that was very helpful, and that was replicated in the adult literature as well. And then the next study that he did that was pretty interesting, because there really hadn't been a focus on reducing sedentary behavior. And so what he did was he looked at whether if you have a child increase their physical activity or decrease their sedentary behavior, which is better. And what he found was that actually you could get children by just limiting the amount of sedentary activity, the screen time that they're having per day, that they actually reallocated that time to physical activity, and also it had an impact on their eating behavior. So at this point, sort of the gold standard is that you really target both the physical activity and the sedentary behavior, but for some families, you can get in there doing one or the other because there could be some preferences. Also, what he found was that the stimulus control, that a way to reduce sedentary activity for kids, many kids actually have TVs in their bedrooms, so one way a stimulus control would be take the TV out, or put a TV locking device on, or monitor that, or turn the TV around, or you can budget that and really reinforce reductions. And again, both those approaches were pretty effective for decreasing sedentary behavior. And why I'm presenting this is I think it starts giving us an opportunity to more individualize and customize the treatment for the family, because we know that targeting sedentary behavior is a very important activity. And so the other piece of research that Lynn has done recently, Lynn Epstein, my colleague, it's been interesting because he's been looking at also habituation, and can you narrow, if you decrease overall variety of foods that people are eating, can you improve weight control? And so that's related to improve weight control as well. So one of the things that we do with families is we do a lot of meal planning, customizing, individualizing, so that they can develop more of these healthy routines. And then the other piece that we've been looking at, I started working with him in the mid-90s and started looking at the problem of weight loss maintenance in kids. And so one of the studies, let's see if I can get this to advance. So Deb, what was the magic way to do it? Just point it? I got it, cool. So this was a study that I did actually in San Diego. And what we did is we wanted to look at, if we stopped the family-based treatment at 5 months and we just let them go, what was the level of relapse versus keeping them for another 4 months and working more on socio-environmental aspects, so moving it beyond not just the family, but also trying to really help with the peer network and better utilization of community resources. And what we found was that adding on this treatment helped, and that the social facilitation was better in terms of weight loss maintenance and psychosocial outcomes. Like, it helped the kids better cope with teasing. They were more likely to endorse it, using actually Jim's measure, support for physical activity and healthful eating. And we also found that parent success, again, maintenance was associated with the child's success. We don't know, it's probably both parent and child, and we found that it definitely was contributed by their reductions in red foods. So we've always used traffic light, color-coded foods, green, yellow, red, and found that even the difference between, the reductions in the red foods were similar for the parent and the child. So what this study basically said is that, more treatment is better, so it's an experimental test, but what it didn't tell us, because it was better than the behavioral skills, but you can still see there is an effect, what about if we could have gone and stood on our heads, and maybe that would be sufficient to get this effect. So the next study we did, we wanted to look at, we did a 4-month weight loss intervention, and then what we did is we compared another year. Well, it was actually 8 months of treatment. It was supposed to be a year, but it was 8 months because the funding got cut. But we had an 8-month intervention, and we either had a 16-week control, and this control was a diet and activity group. We'd go to the grocery store, we'd do all kinds of different physical activities and dietary activities, and that was a control group, so a pretty rigorous diet and activity control. And then we had a matched low dose where we compared the treatment, the control, and the low dose treatment. And what we found was that the low dose did do better than the control. So even having a really rigorous control, this more family-based, individualized, socio-environmental approach had a better outcome. And then the higher dose, the 32 weeks of the socio-environmental was much better than the 16 weeks related to outcome. And we also looked at mediation, and we found that the behavioral and socio-environmental components mediated outcome. So just to summarize where we are with family-based treatment, we know that it does demonstrate effectiveness for youth, and also the nice thing, it shows 10% weight loss for the adults as well. So when we talk with payers, that's important, especially with self-insured companies where they really care about the adult weight loss. Oh, sorry about that. I did skip over this. This is basically just showing you that dosing effect and clinically significant outcomes. But and then the other nice thing, we did a cost effectiveness analysis where we showed it was more cost effective to treat the parent and the child together than the parent alone or the child alone. And one of the great things about the treatment, it really can be customized and individualized, so we felt like that's an advantage for implementation. And it's been implemented with kids 2 to 18 years old, and it can be customized to treat obesity in multiple family members, obesity and comorbidities, and obesity in the parent and prevention of obesity in youth. And so I just thought I'd highlight a couple of more translational studies that we have underway because we wanted to move this out into the primary care study. So we have a National Heart, Lung, and Blood Institute study that is over 500 families. These are really the elementary school years. And one of the things that we really want to look at is not only the impact of the intervention on the parent and child. We have some pilot data to show that it generalizes to other members of the family, which it should because we're working on changing the shared home environment, but we want to systematically look at that. And then we also know that children who have executive function problems, choosing the short-term reward over the long-term reward, tend to struggle more, so we're predicting that the kids who have that profile are going to be especially likely to need this family-based treatment. Another project that we just got funded, which is really exciting, it's a PCORI-funded trial, and it will be with children and adolescents. And the most exciting thing about this is that we're working in close collaboration with American Academy of Pediatrics. So we're going to compare an AMA staged approach where the pediatrician is trained through ECHO as compared to an approach, the family-based treatment approach with providers. So it's really looking at more of a provider-based approach versus a more intensive. And the AMA guidelines recommend more of a staged to gradual acceleration, whereas like the preventive service guidelines, they suggest you just go right after it. If a kid has obesity, you treat it. So we'll be comparing those approaches. And we have multiple stakeholders. So we have over 10 insurance companies that are involved when partnering with us to really evaluate the impact of the program and hopefully work on dissemination. And then these are just to highlight, if you think about Missouri as being a state in special need, obviously we have really high obesity rates here. We're more likely to have type 2 diabetes. One could argue that we really need to target places where they're most in need. And then just to summarize with a prevention and treatment model, this is an updated chronic care model by Dr. Bill Dietz. And basically what it shows, very similar to what Dr. Cole was saying this morning, like we all need to be involved in the best systems that will be set up to really help these children and also maybe prevent obesity from ever even developing in SIBS or other kids, is really to have this integrated system of care. And it's been very exciting to be within the state of Missouri now where we're getting all these multi-sector groups working together. I think that's it. Thank you.